it clear there?
Yes, sir. It's visible. Thank you.
So friends, today we are going to talk about how to manage the distal radial fractures by standardized 5-pin technique. And you know, the distal radial fractures is a common fracture of both elderly as well as young. And when you look into the literature, you can see that it can be managed by surgically and conservative methods. But overall, the literature is very, very confusing. You can see almost equal number of papers for and against all treatment. Let be any treatment like pinning or external fixators or plating or POP, conservative methods or whatever things. There are equal number of papers for and against it. So when you look into it, so what do I believe? The many studies which has aimed to shed light on this, but we are still in a dilemma to decide between the surgical and non-surgical modalities of treatment. Though traditionally immobilized in a POP with a POP cast, it is being revisited as patients are living longer and leading more active lives. So the first, here you can see a conservatively treated, close treatment, very good position, but unfortunately there is no grip. And there is no function here. The appearance is good. Whereas here you can see again a conservatively treated case with very bad position there and ugly shape, but there is a good grip, though it is weak. Here it's a weak grip, here it is good shape but no grip. So that is the question, that is the problem when you face with these fractures. You know, when you can again look into the literature and see that the bridging or non-bridging external fixators, percutaneous cavea fixations, all these things are down now, despite similar functional outcomes, due to its complications like pin tract infections, and most important part is lack of commercial values. Because the companies who make the cavea and the fixators, they don't make much profit. Because if you buy one external fixator, you are going to use it for many cases. And cavea is very, very cheap. But whereas an open reduction internal fixation, what are locking compression plate, it became increasingly popular with within inverted commas, excellent results, because mainly the industry backup and better returns for both surgeons as well as the companies. But my only request is don't forget the basics of fracture healing in all these cases. The first point is in a cancellous area, the bone healing is by creeping substitution. So for that needs a contact. And in the shaft, you get callus, but that need a very good periosteum. In the cancellous area, distal radius, there is not good periosteum. And the more rigid the fixation, you get lesser the callus. And how the voids get healed in a distal radial fracture after getting the reduction, because the impacted area, you get it back into position. You can see the voids there, how it is going to heal. You can see here again, a big void there after reduction, how that is going to heal, because there is no creeping happening there. So basically, most of the stable distal radial fractures can be treated by non-operative means, closed reduction and cast immobilization, where they are inherently stable distal radial fractures. So how to decide which fracture is stable, which fracture is unstable? I usually judge it by the X-rays based on the LaFontaine criteria. When you have a more than 50% dorsal comminution, when the dorsal angulation is more than 20 degrees, when there is shortening of more than 5 millimeters, when the ulnar styloid base is fractured, and with age more than 60 years, and significant soft tissue damage. So these are the criteria which indicates the fracture is unstable or difficult to treat. So if these fractures are present, a loss of reduction in a cast is very, very probable. Hence, consider operative treatment. So we have been trained to do the percutaneous pinning, but unfortunately, there is no standardization in pinning. If there are 100 orthopedic surgeons, there are 100 different types of pinning, but there is no rule on that. Whereas when you deal with a locking compression plating or a volar locking plate, you can put the screws only through the holes. So it is designed for dummies. But whereas pinning, though it looks simple, it has to be applied in the right place and right way. The plate is automatically idiot proof. You can see here, this fracture is being fixed and that is the result. It has completely widened out and collapsed here. The earlier case also, it is completely collapsed. So the percutaneous spinning with K-wire, there are various types of percutaneous spinning depending on the whims and fancies of each surgeon. And most studies attribute poor results because of loosening and loosening proceeding on to infection. And loosening and infection produces instability, radial shortening, and stiffness, and even CRPS. So because of these things, the pinning is gradually going out. So my request is to read between the lines and make our own conclusions. Is there a way to prevent the loosening, and is there a way to standardize it? Now we have a lot of poor people with distal radial fractures who can't afford the mainstream treatments and still need a good quality function for working even in old age. So what is my choice of surgery? In all volar buttons, I use volar locking compression plates. In most other unstable fractures, I use a standardized 5-pin fixation. The standardized means there is a particular way of fixing. It is not like haphazard way of putting pins. So I published this article in the Journal of Trauma, me and Dr. Lohit. And to come to the point, what is pipe-in fixation? It's a fragment-specific, lockable, adequately stable fixation with joint sparing external fixator properties, the most minimally invasive, functional, least expensive, and suitable for most unstable fractures. So when you come to the 3-column theory, so these theories are all prepared for the platers. It is for the industrial use of how to use the platings. But you don't use this thing for a pinning. So we have to fix both radial column, the intermediate column, and ulnar column for stabilizing. But unfortunately, due to the conical shape of the distal radius, when you put all the wires, you can see the wire will cross very near the fracture site. So at this point, it becomes just a bigger wire. So the instability is at this area, and this wire will rotate around this place, and it becomes unstable. And the another more important part is, these are the deformities of the colles fractures. So 2-3 points there. So in the examination, you have to write all these things. But is it possible to have a deformity like this in the real life? You just try to break a wooden piece and to try to make this deformity. It is impossible to make a dorsal displacement, dorsal tilt, lateral displacement, lateral tilt. It is impossible for these things. But actually, it is an illusion. That is, the fracture is simply a supination. It fractured at the diaphyseal-metaphyseal junction, and the fragment is supinated. When you take an X-ray in APN lateral, you see all these deformities because the 3-dimensional thing is converted into 2-dimensional thing, and you read it like this. So this is an X-ray reading. The real deformity is only supination and impact. So all other things are illusions. So the mechanism of injury, when you fall on outstretched hand, the distal part of the wrist is stable on the floor. And fracture takes place at the diaphyseal-metaphyseal junction. And it is the proximal fragment which in reality displaces. It is not the distal fragment which is displaced. So the more soft tissue injury is happening onto the proximal fragment, and distal fragment is basically stable. And when you do the plating, you put 3 screws on the proximal fragment. You stabilize it well. But whereas when you do a K-wire, all the wires are on the distal fragment. And the proximal fragment, I told you, all the wires are joining together at the fracture site. Your stability in the proximal fragment is less. So that is one important point there. And when you take an APN lateral view in the supination position, it is projected as the above complex deformity. It is just an illusion. So to get a reduction is very, very important, but you must get a stable reduction. So reduction, once you get a good reduction, that basically becomes stable. So to reduce it, you just have to disimpact, distract, and pronate it back into position. So there is no need of traction, counter traction, and all those things. You just have to disimpact, distract, and pronate it back. Check the relationship of both radial and ulnar styloids and confirm it by Shyam. The dive punch fragment, if any, may be elevated by percutaneous K-wire as a joystick or any other methods. So I'll show you the reduction technique. So now I am just disimpacting. The single method disimpact and rotate. Just pronate it. So that is the reduction. You don't have to do anything else. You just have to disimpact it. So the impaction is gone and pronate the fragment. So, and get a check X-ray, check Shyam and confirm it. So before going on to it, think about the deforming forces after reduction. What happens? The brachioradialis is inserted into the distal part of the fracture. That means that is only tendon or muscle which is inserted into the distal fragment. All other tendons of the forearm, they bypass the fracture and have a concertina effect to collapse the unstable fractures. It just bypasses the fracture and goes to the wrist and hand, and it tries to collapse the unstable fracture. And the proximal fragment is under the control of biceps, supinator, pronator teres, and pronator quadratus. So when you rotate it, the proximal fragment, if you are fixating only pure K-wire, as it crosses at the fracture site, your biceps and supinators will try to control the proximal fragment and makes the fracture unstable. So I have designed all the wires to counter all these forces. So as you reduce it like this, I pass the first wire from the ulnar head across the inferior radioulnar joint to the distal radius. A subarticular, if it is a subarticular fracture, it's a subarticular wire that maintains the length of the radius. Take care when there is a radial styloid fragment. If you have a radial styloid fragment, this wire tends to push the fragment out. In that case, you have to put a radial styloid wire first. And the second wire is a radial styloid wire at 45 degrees oblique in both AP and lateral planes to catch the proximal radial cortex on the ulnar side, proximal to the fracture side. And that is the lateral view, that is the AP view. That fixes the radial column. Now the third wire is listage tubercle wire to engage the volar cortex on the proximal radius. It may be a Capenghi or an intrafocal wire. And take care of the extensor pollicis longus. So always try to stay on the radial side of the listage tubercle. That prevents the dorsal tilt. Now the fourth wire is the ulnar corner wire on the radius. From the dorso-ulnar corner of the distal radius to the lateral cortex of proximal radius. That fixes the intermediate column. Now all these wires control the distal fragment well, but it is not good for the proximal fragment. Because at the proximal fragment, all these wires converge here. So this proximal fragment can rotate around this. And the proximal fragment is still under the influence of two pronators and pronators, supinators and biceps. So to break that, you need the fifth wire. That the fifth wire is the proximal ulno-radial wire. From the ulna to the radius, you can be in this direction. So nowadays I prefer a wire like this. So that is divergent wire. It's a crucial wire as it effectively counters the deforming forces of pronators, supinator and biceps. So this is your AP view and lateral view at the end. In a good bone, all this works well in the unit as the base of unity is strength. All joints together then works. Together it locks the fracture site. So it can counter all the deforming forces and you can mobilize the nearby joints also, except forearm movements for about 4 to 6 weeks. So if you feel you are doing in a very old lady like this 86-year-old lady and the bone quality may be very poor, in such a case, you can connect all these wires with a humex. So it becomes all locked in the position. So you can fix it in the humex like that. And look at this 82-year-old lady with a displaced fracture with a comminution there. This is how I have reduced. And you can see the divergent wire here. We have subarticular wire. So the wire is looking like this. But I cannot rely upon these wires because the bone quality overall is not very good. So such cases, you can make it two pieces or you can a single K-wire bend like this and connect it. So it can be single wire, it can be two wires also. You can keep one there and one separate also. It is not a problem. You can connect together and see the patient next day in the post-op period. Next day patient is discharged. That is a movement in the fingers and she moves the wrist and this is splending. Just give a small splint and that is the reduction. So I'll show you some cases. See very dorsal comminution and a far distal fracture with a comminution there. So this is how I have reduced. You can see the subarticular wire and maybe some few extra wires also may be there depending on the comminution. And that is the final function after 3 years. See, that is the X-ray. You can see the scar. So that is the X-ray. So this is another case. You can see the comminution again here and dorsal tilt. This is how we have. This is actually two wires fixed together like this. And at 6 weeks, I removed two radial wires and the radial wire alone. And that is the function. There's another case where you have the distal ulnar fracture. When you have a distal ulnar fracture, when normally in such cases, you can see the ulna is acting like an external fixator for the radius and joint sparing external fixator here for the radius. So when the ulna is fractured, so that function will not get, your wire will not work. So in such cases, you have to modify the entry. You keep two wires for the ulna. And you can put an external fixators also there based on the stability. So that is a healing. The old lady, you can see the function. So you can see the comminutor fractures, another case, all well reduced just by pronations, and that is the function. So here you can see the dorsal lip fracture. So this was the X-ray looking like. This is how I have reduced it, fixed, and that is the function. This is after 3 years. So you can see the dorsal lip again, a small lip, reduced. You can, after reduction, you can see that, put a pin. Another case, that is the function. So this case actually was posted for distal radial plating by some other institute. He came to me and I fixed it like this, 6 weeks X-ray and removed the wire after 6 weeks, these radial wires. And that is a 7-month follow-up. That is his function. You can even use it in compound fractures. You can see that wound closed after debridement. There is no consensus on the best treatment for the distal radial fractures. The indication for surgical treatment are judged individually based on the balance of risk and benefits. Thank you for your kind attention. Thank you. Yes, sir.
Yes. Thank you, sir. Nice presentation. I have two questions. One is you passed two ulno radial wires. So what is your, how do you immobilize post-op? That is number one. And number two, when do you remove those wires and when do you mobilize the patient?
Yeah.
Ulno radial wire.
Yeah. The ulnar radial wire is kept for 6 weeks.
And position of immobilization?
Neutral position. Forearm in the neutral position.
No need of supination, sir.
No supination. In the neutral position, they can do better.
But do they do pronation, supination, rotation movements of the hand?
With that, they should not do it. With the pin, I inform them that I have blocked the forearm movement for 6 weeks. After 6 weeks, I remove the radial ulnar wire. Then only I start the forearm movements. And 8 weeks, I remove the rest of the wires.
So the cast is above elbow?
No cast. Just a splint.
Splint.
No plaster at all. Yeah, aluminum splint. In the functional position.
But then in that functional position, they might rotate, which is very different.
Two wires will not create any problem. 2 wires, there is no issue. I'll show you the splint. It is just an aluminum splint. So that is the aluminum splint. And to see that if you keep 1 wire, there's a chance of wire breakage. 2 wire breakage is practically nil. But again, you see that you just keep little bit tip on the other side. If at all any problem, you can remove it from that side.
So in your experience, did you had any wire breakage due to rotation?
No. 1 wire I had. When I put 1 wire, I have seen that. With 2 wires, I have not seen it. But inform the patient that I have blocked it. You should not attempt for doing that forearm movement.
Right. Thank you, sir. Any other questions to Vasudevan, sir? Okay. Thank you very much, sir.
Right.
Yeah. Please stop your, yeah. So we move on further. I request Dr. Gadegone, sir. So, sir will be talking on 10 commandments of successful OPD practice in rural ortho OPD. So, Gadegone, sir, please. And we are extremely sorry not to inform you in advance.
कोई बात नहीं. Am I audible and visible?
Yes, sir. Yes, sir.
So, thank you very much, Khodke sir, for inviting me to deliver this lecture. I welcome all the dignitaries, those who are presenting on this platform, and also I must thank the President and Secretary of the Western India Orthopedic Association for bringing out such a nice idea of Sunday evening master class. So this is, I am presenting on a 10 commandments or 11 commandments of successful practice in the rural setup. I am Dr. Vasudevan Gadegone, at present President of Maharashtra Orthopedic Association and working at Chandrapur, consultant orthopedic surgeon. So any pillars of hospital, it is nothing but a teamwork which works. Your staff, subordinates, your anesthetist colleague, your paramedical, they are backbone of any successful practice, whether it is in urban or rural setup. So you have seen this video which depicts that it is how it is very difficult to work in the rural setup, a orthopedic practice. It's because of many factors. And then one feel that whether we are starting the prior practice in rural area, is it like a effect of "aa bail mujhe maar"? Whether to start a practice with very meager investment, very positive of the infrastructure. So I welcome you here, willing and committed to provide a quality treatment within the ambit of socio-economic factors to make successful practice in rural area. Now we can see how we are facing with the problems. This is the problem of where the patient, how to transport. This is the problem where a crowded hospital and they don't have a proper facilities at the rural area. So गालीचे आपके देखेंगे फिर कभी, अभी तो पाव कीचड़ में सने हुए हैं. और it is this, whatever I am telling, it's a very eye-opening to the all orthopedic surgeons, those who are talking of a very highest model of treatment and corporate hospital culture. So problem is in rural setup, limited resources, limited expertise, low socioeconomic condition, less facilities available. Overcoming those is a real challenge. Key to success is a mission and vision. Whether you practice in rural area or in urban area. Go step by step, never try to jump. Planning, determination and education is the goal. And then you will get a sky is the limit to not only you are economically sound, but you are socially also, you are at the highest platform in that particular area. These are the 10 commandments of successful practice: attitude, well-equipped place to practice, service to rural people, connection with the community, focus on relief of symptoms and not physician qualification, delegate responsibilities and make sure there are processes for catching mistakes, upgrade yourself, incorporate appropriate new technology, undivided attention and invest in reputation management, relationship with the patient, and not to criticize your own colleague. Now we'll go step by step. What is attitude? Attitude is a settled way of thinking. Positive and healthy attitude matters and not the place. Things work out best for those who make the best of how things work out. So when you are ready to work in a rural setup, आपला attitude is the best that helps in practicing at the rural setup without criticizing what is available strata of the patient and the facilities. Social consideration is the most important. Studied in this environment where 5-star hospitals, and then you can see how you remain in the society, mostly the foreign fellowships and very many higher education. But what you see in the practice, facing the patient and competing with osteopath and hakim is the reality of the rural setup. It is our attitude that will determine the ride. Our attitude and efforts should address the need of community where we practice, and that is said none other by a Padma Shri and Maharashtra Bhushan Dr. Abhay Bang, who is working in a very, very remote place of Gatchirudi in Adivasi area, and he is riding on the horse and doing a great job for the society. Practice at a smaller places सपना एक देखोगे मुश्किल हजार आएगी, लेकिन वो मंजर बड़ा खूबसूरत होगा जब कामयाबी शोर मचाए. Because it is a very positive attitude and small place. If you are a very good service oriented doctor, you will become a very famous and respectable person in this society. Be the change that you wish to see in the world. The future of medical practice lies in the rural area. But time has changed the attitude for achieving the final goal, a real peaceful pleasure. Well-equipped place to practice even in a rural setup, it is possible. A strata of patient in rural area also changed, hence make your hospital well-equipped. Train your staff, though they are not very well educated. A spacious reception hall, and you must have an identity of a consultant who is working in hospital, and he should be available whenever it is patient's need. Consultant's chamber with attached X-ray unit and minor OT is a asset to the any general orthopedic surgeon. Computerized OPD setup with a computing device, keeping record and retrieving of the record, it is possible even in the rural setup that does not require a very high-fi sophisticated instrumentation and place. That differentiate you from your competitor and satisfying your market needs. Therefore, it is mandatory to have a X-ray unit, minor operation theater, and consultation chamber together in a rural setup. In-house technology, X-ray unit is must nowadays. Whether you work in the rural area, that does not matter very much. CT scan and MRI is not a luxury, but it is necessary and it should be available, at least not with you, but nearby places. That makes your job easy. Meeting hall with a capacity of around 20 people. If you are in a district place, at least where 25 doctors are working together, you can have a small meeting hall, and that will also give exchange of knowledge opportunity amongst the rural doctors, and it will also help in solving the day-to-day problem of difficult cases. Entry-level NABH accreditation organizes everybody as a team, and nowadays it has become a mandatory thing in a rural setup also. Service to the rural people, patient intimately understand how they were treated and will rate their overall service experience and shall share with friends. They don't see your degree, they see how you are behaving with the patient and how you are affectionate with the patient. Conversation should be in the patient language and mix up with the culture. That is the most important thing. Suppose you are a highly placed doctor, you are only of knowledge of a very elegant English version, but if you are working in a rural setup or people only understand a Marathi or a Telugu or a Tamil in that particular, how you are going to convert with them, and then they will feel that the doctor is not of ours. Therefore, wherever you practice, you must adopt the language of that particular area. Mission to serve the masses. Mission is to serve the masses, and that should be your goal, and this is how it should be done. Connect with the community, formation of various clubs, do charity also, affiliate to charitable trust, your hospital, health awareness camps, engaging people in a health related seminar in a local language, that also helps you to increase your patient strata and also the practice. Be loyal, hardworking, passionate, and sincere to your patient. It pays you surely. That can produce new patient volume and a better mix-up. Satisfied patient work as an advertising agent. That is the most important thing in rural practice. Patient focus on a relief of symptom, not a physician's qualification. When they come to your chamber in a rural setup, they are not bothered whether you are a MS, MCS or highly placed doctor from America or England, and you know all gadgets of highest of quality. What they know, what is the approach to the patient. बड़ा हुआ तो क्या हुआ, जैसे पेड़ खजूर, पंथी को छाया नहीं, फल लागे आती दुआ. If you are not very approachable to the patient, then what is the use? A doctor in need is a doctor indeed. Highly qualified doctor, not accessible to the patient. They do not like it. This is the most important thing we have to consider. Patient focus on a relief of symptoms and not on a physician qualification. As I said, human wants to know what is in it for us. Patient want to feel better and cure. Modification in treatment plan which suits to budget of the patient is very, very important. Adopt the technique which are economical, but giving the comparable result. As now, Vasudevan sir has given a very percutaneous osteosynthesis of a lower end radius fracture, a cost-effective treatment, giving a similar result of a very highly specified multi-locking plate system. Results are ultimately same, but one surgery cost near about 15 to 20,000 rupees, and other cost near about 60 to 70 rupees, where from a rural guy will bring those money. Do not be after money. Money is a byproduct of successful practice. If your goal is just to make a money, you won't succeed. If you are a successful, money will follow you. Money is an commodity to use, not to be dictated by. If you are a successful, there is an accompaniment. Frank Lowe, work in such a way that money will follow you. Undivided attention and invest in reputation. Be always kind to the patient, never harm them. Respect your colleagues. Invest in a reputation management. Correct mistakes and false information. Create your own content. Embrace constructive criticism. Address actionable items. Learn to listen to set a good standard practice. Learn to listen to patient relatives and your well-wishers in language they understand. Listen to your own self. Learn to listen unhappy patient. Reassure them and you know your limits. Do not accept the case you cannot deal. Take opinion about the difficult case. Refer the case to the higher center in difficulties and don't say that I know everything, because that is where you are mistaken for the first time. Come bull, do hit me, no heroic thing. Accepting the patient with very LL beams, Lutza, Lapanga and Badmas patient, you know there is a category where the patient, they behave in an erratic way. Himself invited a trouble by accepting such a patient, and then why he has treated this patient. When the patient's failure, or he does not give you money, or he tries to create a nuisance in a hospital. So we have to learn the technique of which patient is devoted to you, which patient you should take, where to refer, and gracefully retract yourself if you are not able to do a surgery in that particular person. Delegate responsibilities and make sure the processes for catching mistakes. In rural area, difficult to get trained staff. Train them. Teamwork is the real key to the success, as I said in the first slide. Upgrade yourself and incorporate new technology. Attending workshops and conferences, try to learn and master new technique. At least you may not practice it. But when the patient comes with the bundle of MRI and reports, you must try to understand that the patient needs your help and your advice. You must know what is inside that bundle. incorporate appropriate new technology to improve your result of surgery. Technology always pays and improve your results. Albert Einstein quotes, the whole science is nothing more than a refinement of everyday thinking. I believe this concept. Technology is a tool to progress, but cannot be an ultimate success. And don't be like Abhimanyu, where you cannot you cannot surpass that chakra view of a newer technology. Know your limits. Pre-conference workshops, hands-on training. However, anything new may not be necessarily good. The patient will never care how much you know until they know how much you care for them and what is the result orientation at surgery from you. Relationship with the patient, embrace an enjoyable working relationship with the patient. Be kind and social shall reduce the need for additional promotional resources of practice. Baba Amte says, I sought my soul, but my soul I could not see. I sought my God, but my God eluded me. And then I sought my sisters and my brothers, and in them I found all the three. So, Jeka ranjale ganjale tasi mane jo apule, dev tethechi danava, dev tethechi udra. So what is this? Baba Amte said कि गोर गरीब की सेवा करो वही भगवान है और कहीं नहीं है. Not to criticize your own colleague, respect your colleague, you may need their help. Bad news spread very fast, untoward incidents, negative impact in practice and more so in rural setup because it's a small population strata, everything spreads overnight. Kabir quotes, बुरा न देखन मैं चला, बुरा न मिलिया कोई, जो दिल खोजा अपना, मुझसे बरा न कोई. Why to criticize other doctors and other people? We have to improve ourselves, and that is the best policy instead of criticizing others and finding fault with our colleagues. Treatment should be available, affordable and accessible for the large majority of the population, without violating the principle of osteoarticular reconstruction. Patient respect to doctor next to God. If you practice in a perfect way, without going behind the money and without deceiving the patient by using a useless technology where it is not very much result oriented. And you can see L Prakash Amte from Kasa, a rural area, has spent his lifetime serving the people and where he is at the top of the social sphere. Keep three words in pocket: try, true, and trust. Try to ignite positive thinking. True with your work with a smile on your face. Trust in God. Whether you are in the rural practice or in a urban practice, it does not matter very much. अंतरात्मा की आवाज में आपको एक ही चीज मालूम होना चाहिए कि I have not harmed today to anybody, or money in my patient has not been shifted from this hospital, and that will satisfy your ego, internal, not external. Success is not an accident. One need to have a mentor. One need to have a guru. I always respect my guru from my primary school to up to my post-graduation, double post-graduation, because guru bina kuch bhi nahi hai. And then what is success? Successful clinically, successful financially, not facing court matter, maybe civil, criminal or consumer. This is not a success. Upholding self-esteem and ego, no. To see a smile on a patient pain when you leaves your OPD, that is the success of your practice, whether you work, and that is more than what you earn. You cannot compare the happiness of the patient on a scale with the amount you earn from the patient's pocket. but we have to pay the price also. हकीकत में बदलने से कब इनकार है सपनों को, मगर इसके लिए खुद को जगाना भी जरूरी है। किताब ये जिंदगी ने पाठ है पढ़ाया है हमें, खुद को बनाने के लिए खुद को मिटाना भी जरूरी है। सो ये डॉक्टर्स की लाइफ है। दिस इज अ वेरी इंपॉर्टंट डिवोशनल लाइफ ऑफ द पेशंट. की घेतले भरत नहे आम्ही अंधतेने बुद्ध्याची वाण धरिले करी सकीचे. You know that we have to devote your whole life for the betterment of a poor people. And interview with the successful medical practitioner. Do we go out and have a fun with friends and do crazy things? He said, no, he is not a successful doctor because you have to see yourself also. And then do you do 69 with your wife or girlfriend or mistress? And he says, no. What is the use of such a life of a doctor who does not enjoy himself also? Doctor, you know what? I really do not understand why you want to live on this earth. Take home message. Passion, mission, and hard work is the key to the success, or those who are successful, they have to devote their time. They have to work for the betterment of the poor and downtrodden. Then and then you will become a bigger and bigger, not by earning and moving in the Mercedes car. Thank you. And success is not the key to happiness. Happiness is the key to success. If you love what you are doing, you will be successful. This is my take-home message. Thank you very much. Thank you very much.
Thank you, Gadegone sir. So the success mantra is a smiling patient going out of your OPD. Very nicely said. But your topic was commandment for rural ortho practice. But I believe all these commandments do hold true for urban ortho practice also. Wherever we are practicing, all these commandments do come into picture. Thank you very much, sir. So any comments or any questions to Gadegone sir? Thank you very much.
It was an excellent talk.
Yes, sir.
Yeah.
So I invite Dr. L Prakash for his famous extension casting for humerus and forearm fractures. L Prakash sir, please.
Yes.
Share your screen. Yeah.
1 minute. Yes. Good afternoon, friends. I had a very late notice, so I'm using my ready-made slides. Anyway, I've given this talk a few times. Extension casting of humerus, a new non-operative method of managing fractures of humerus. Now, Epictetus said that it is impossible for a man to learn what he thinks he already knows. Most of us doctors have learned so much that our cerebral hard drive is full. And when anything revolutionary or out of the way comes in, we refuse to accept it. It is a well-known fact that keep two ends of humerus in the same room and they will unite unless an orthopedic surgeon enters that room. There are two types of surgeons. One who conserve the humerus fractures and those who operate the humerus fractures. Those who operate the humerus fractures far outnumber those who conserve the humerus fractures. And we all see not one, but numerous results of operated humerus fractures with broken plates, floating screws, infection, pouring pus, multiple surgeries. The last patient I did Elizra on for humerus had 15 failed procedures, 15. And you can see the extent of disasters that most people are left with. The one on the right was a child of 12 when he presented to me. He had a fracture of humerus when he was 5 years old and was treated with an adult plate. Even if nothing was done, the child would have united. And by the time of 12, he had had 6 surgeries. And this was a situation when he came in, you can still see that the epiphysis is not united. So floating plates, bent nails, ender nails failing, locking nails failing, bolts going across. All these scenarios are very, very common. I still don't understand the fascination for surgeons to go in and operate on a humerus, which is a bone that hates metal. Keep 2 ends of humerus in the same room and they will unite unless the orthopedic surgeon enters the room. In the past, there was some trouble about humeral union by non-operative means, which has now been fully conquered. Humerus is an adamant bone and hates metal. Few daring surgeons enter the room and come out unscathed. Non-operative management too is not sometimes successful, or in other words, not always successful. And this is because of wrong operative methods. What are the wrong operative methods? U-slabs, U-casts, hanging casts. All the methods that immobilize the elbow in flexion and use a sling are wrong. So every single of this method is wrong. You will say that, do I dare to tell you that textbooks are wrong? Of course, textbooks are wrong. If you treat a humerus by flexion, you are going to displace it and you are going to cause angulation or distraction, or if you hang it with a heavy cast, iatrogenic distraction, non-union, bringing a bad name for close treatment. So are all textbooks wrong? Textbooks need diligent scrutiny of data, at least 1 or 2 meta-analysis, and so they are all 10 years stale. This is an orthopedics of future, which will come in textbook soon. If these are all wrong methods, what is the right method? You can see from these examples, wherever a sling, slab and U-cast was put, the humerus was angulated and in a bad shape. The instant it was converted into extension cast, it fell straight in line. The method is extension casting for 4 weeks and then an arm gaiter or a brace till union. That's all that is needed. The question that is asked is, what about elbow stiffness? An elbow cast in extension up to 6 weeks never gets stiff. I have a study of 42 normal elbows. Patients without any injury who were incentivized in the prison to have their elbows cast in extension. And from as little as 21 days up to 6 weeks, I cast normal elbows in extension. And every one of them regained full flexion within 3 to 4 days of removal of the cast. These 26 normal volunteers up to 6 weeks as part of my prison experiments recovered full movements in 48 hours of removal of cast. And that paper is under publication, accepted by a very famous reputed international journal, should be coming out soon. So all we need is extension casting for 4 weeks, an arm gaiter or a brace till union. After I exposed about this trick initially in the social media, a wide range of younger surgeons started following it. And to date, over 3,000 to 4,000 humerus fractures have been treated by this method in all ages, all sexes, obese patients, young patients, old patients, with uniform, consistent union within 6 to 8 weeks. Now, this is a simple example of a doctor. She is a postgraduate doctor. She is a daughter of a doctor herself, had a fracture in Mumbai, advised surgery by 6 orthopedic surgeons. We treated her in extension cast. I did not see the patient. I just gave an advice to one of my junior orthopedic colleagues, and that is her mobilizing the hand from day 1 of casting. That X-ray in 3 weeks' time. At 3 weeks, we changed to an arm necklace cast so that the cast doesn't slip. And that's her movements, restriction of elbow only because of the length of the cast. And that's her ensarmento brace. That's about 2 months. And that's her in 3 months, back to gym, back to work, scar-free and fully functional. And there she says that first day at gym successful, nobody could believe that I'm back in gym in 3 months. So that is how simple extension casts are. You can see a heavily comminuted feature fracture on the left. In 71 days, the fracture is united on the right. Again, a comminuted fracture on the left. In 60 to 70 days, it gets united. One more example. The fact is, in extension cast, union is a rule. No scar, no sutures, no metal, no foreign body, no resurgery, no anesthetic complications. The important trick is the cast has to be light. You can see the cast, you can hardly see the line of the cast. So they're all single layer casts. The patient is encouraged function from day 1, encouraged to lift and raise the hand high up in a rifle gunstock manner. And even this much of gap, as the patient starts moving, will join up and glue up beautifully. This is because biceps is a deforming muscle, while tricep is a conforming. The instant you flex the elbow, the fracture humerus is going to deform. And the moment you extend the elbow, fracture humerus will automatically straighten up. This has been known to bone setters for thousands of ages. Unfortunately, the orthopedic surgeon came in and some sound is coming there. Unfortunately, the orthopedic surgeon came in and he messed up the situation. Next time, try extension casting for 4 weeks and then put an arm gaiter brace till union. Thank you very much for listening to my talk patiently. And if there are enough listeners who have actually heard the talk, I am sure there should be many questions. And here I am to answer whatever questions you have. The talk time allotted was 15 minutes. I deliberately completed in 12 minutes so that we get 3 minutes of question answer session. Dr. Ashok, yes.
Yeah, sir, very interesting talk, sir. The case which you showed, Dr. Shivangi, she's from my institute. She is from my institute, and she was treated by Dr. Sheval Chavan. He is my associate. Yeah. So he had shown me all that, and they were like not ready for surgery. And yes, very good results.
My mother is also a very close friend of mine, and she's a gynecologist.
He's a gynecologist. Yes.
And we did her online treatment. So
online. Yes, sir. Yes. Very nice result.
For this.
Excellent.
So we have, that's only an example. There was the one which I had in hand to show. And we have numerous cases. So I think there are people who are already convinced that yes, extension cast works. We have to just get away from the ego mentality of putting a plate for every humerus.
So Yes, sir. So one question,
Yes.
we are also following since we saw Shivangi's case. So we had almost done 8 or 9 cases. In one case, we experienced a radial nerve palsy, which was not there pre-op.
Actually, it is a little rare to have an intra-treatment radial nerve palsy unless it is a long oblique or a spiral fracture along at the place where the radial nerve winds around the humerus, which will happen more often with the flexion than with extension. In any case, it is only a neuropraxia which would technically settle with some steroids. Though some surgeons deliberately open the radial nerve and isolate it and then plate it, I personally haven't seen, I've seen just one transient neuropraxia in one patient out of my first 100. That too in a long spiral fracture, which was around the area of radial nerve. I simply disregarded, gave him a coccoflint and gave him some steroids and said, when we start flexing the elbow, it will become all right. And it became all right. What happened to your case?
So then we converted into a surgery, sir.
Because surgeons are a little worried that we can't be responsible for a wrist block. So there obviously would have found that the fracture fragments and the nerve would have been closely in association. And you would have to isolate the nerve and then plate it and then keep the nerve safe to avoid the wrist block, just what the textbook protocol. But even if you had not done anything, it is unlikely that the callus would have incorporated over the radial nerve or caused any permanent injury.
Right. And one more question, sir. How do you manage for the edema part, which comes in the hand?
Actually, I didn't put the photograph here. We have to tell the patient to raise the hand above the head 10 times a day from day one. So they start pendulum movements and then 10 times they have to raise the hand above the head. While sleeping, they have to keep it either on pillow on above the stomach, like this, that is, the pillow has to be higher on the heart, or they keep the hand like that when they are sleeping. So edema doesn't come. For somebody who is always used to flexion cast, these are the questions that will come to their mind. That the hand will be swollen like a pumpkin, and people might get wrist drop, and extension cast is what is given by pahalwans and bone setters. This is not scientific and the like. But I think if you master the methods, this is more scientific than any operative method for humerus.
Primary radial nerve palsy, if it is there, sir, then how do you advise a cast without going into details of the radial nerve palsy?
There are two types of X-rays which will be associated with radial nerve palsy. One is a closed fracture with a transverse or a short oblique fracture with a radial nerve palsy. That is invariably a neuropraxia and has to recover by conservative method. How will you treat? The other one is a sharp spike, long oblique or a spiral fracture in the exact mid shaft of the humerus associated with the radial nerve palsy, where there is a good possibility of nerve entrapment or the spike of the fracture causing neurotemesis, or maybe an indication for nerve exploration. In the second type of cases, fixation of humerus is the secondary. Primarily, our job is look for the nerve, isolate it, safeguard it, and then do the, having opened it, you might as well plate the humerus. But if I get a wrist block with a transverse fracture or a short oblique fracture, I'm not going to bother about the wrist block. I know there's neuropraxia. I'm going to treat him by extension cast and put a coccoflint, and I assure the patient that it will do.
Right. Any other question to Dr. Prakash, sir?
Thank you very much.
Thank you.
And I think you're curious
Yeah.
and eager to learn here from Dr. Karne. So I'll switch off my mic.
Thank you so much, Dr. L Prakash. So we move further. So this is our last talk for today. I invite Dr. Karne, sir, for his talk on injection in OPD orthopedics. Karne, sir, please.
Can you hear me?
Yes, sir.
Well, thank you very much for giving me the opportunity to have an interaction with this august audience and giving the new concept of the office orthopedics. Now, we are going to talk on this injection techniques in the orthopedic OPD, what we can do for that. What is the Indian scenario? A few decades ago, all of us were almost trauma surgeons. But now, as a number of trauma surgeons is increasing and people are also becoming more much aware, the non-traumatic and the degenerative orthopedic conditions have increased multifold in our OPD. Because most of the OPD patients are of this type, it is almost 80 to 90% patients in the OPD are of this kind. And what a common Indian patient want. These are the common Indian patients, and most of us from either the periphery or in the suburbs, we get a rural population, as well in the city also we get a middle and the lower socioeconomic people. They want sustained long-term pain relief, but that also without surgery. And what happens when he goes to all the doctors? He's given conservative management, which is generally in the form of either the medicines or the maximum is a physiotherapy. But when he doesn't get relief with all this conservative management, then he's naturally advised surgery. But this patient is scared of the surgery. What he thinks is surgery as a last resort. At the same time, he goes to the other pathies, and the other pathies, they lure him by having the tall claims that we can cure everything. And there are certain agencies also which has come up in these metros that they can treat everything conservatively. Some do get the satisfactory result, but then at least for some period of time, and when they get the satisfactory result, the allopathic science is criticized because they had advised surgery, and then doctors are accused of looting as well, a knife crazy, etc., etc. So even after surgery, also patient spends a lot of money. So the expectations from surgery are very high. There is increasing number of the dissatisfied patients after surgery, especially in the degenerative conditions of the spine, shoulder, and early arthritis of the knee also. If they operate TKR in the early arthritis, generally patient is not that happy as when we operate for the advanced arthritis. And when there is a dissatisfied patient and when his expectations from the surgery are not fulfilled, there are very few who actually express these unhappiness openly. Now, this is one of the slide of this Times of India. He's a column writer there, and what he is written that about the surgical strikes better for surgeon than the patient. What I want to is this very important because it is one represents the actually psychology of a common patient. That to combat my severe spinal arthritis, I underwent a major surgery on my back last year. The surgeon reconstructed 3 vertebrae using titanium rods. Alas, 1.5 years later, the pain is almost as bad as before. On every post-op visit, he takes an X-ray of my back. He looks admiringly at his handiwork and almost as though he's in love with it. It looks really good, he says. Just use a better pointer. Sorry, I say, but the operation was supposed to end my spinal pain, but it hasn't done so. Don't worry, the X-ray shows you are doing fine. You will get better in due course of time, says the surgeon. In the X-ray, another admiring gaze. This operation has left the surgeon delighted without curing the patient. So that is the scene which we see in our OPD most of the time after surgery for the conservative, for the non-traumatic situations. So the doctor thinks, what is the solution? Because they also don't know what can be offered apart from the current conservative management. When we give the medicines, we give the physiotherapy, but what else can we do? He thinks that is there any conservative modality which will give long-term relief and which will reduce the dependency on the NSAIDs because of their own complications, long-term complications. So corticosteroid injections is one of the most important tools to treat such patients. But remember that it should not be used solo. It should be combined with the maintenance therapy. That maintenance therapy is in the form of either heating, proper exercises, because this word is very important, proper exercises. Then back care, back and joint care, all these things are combined together to give the long-term sustained relief to the patient. Now we'll talk only about the injection. These are the corticosteroid injections. I'm not talking about PRP, BMAC or other injections. There are different routes of the injections. Either one is intra-articular, second is a local. Local also is with needling and without needling. And third thing is the epidural injection. Now these are indicated when there is a need to reduce inflammation and improve the function in a variety of musculoskeletal conditions, which are secondary to either the inflammatory, late traumatic, or the degenerative. As I told, when combined with appropriate multimodal therapy, they can reduce the dose of the systemic drugs or the dependency on the reduce the dose of the even DMRDs and improve the quality of the life with pain reduction and better function. And we can postpone the surgery for a long time, especially the knee replacement, the spine surgery, especially in the stenosis, which are the gradually increasing conditions. Of course, it doesn't have the much systemic effect as an addiction like the oral steroids. So I discourage patients for taking the oral steroid, but I encourage them to go for the local injections. Now there are different injections we'll see one by one. What are the intra-articular indications? These are in the degenerative arthritis, which you find in the knees, ankle, hip, the first carpometacarpal joint in the tarsometatarsal joints also. Then the non-infective inflammatory synovitis arthritis like rheumatoid arthritis, but not crude rheumatoid arthritis, but they are having the synovitis. And then here we have given right from the hip joint to all the joints, shoulder, and to the interphalangeal joints also in the rheumatoid arthritis. The shoulder, elbow, wrist, and IP joints. Then there are certain chronic pains in the shoulder joint, which we find on MRI. There are small tears and tendinosis and impingement. There also they are extremely useful. Rather, my surgical incidence for such chronic pains is hardly 1%. Then I have given the temporomandibular joint also when there is a fibrous ankylosis or even the synovitis or the pain at that site. The another indication for the local without needling, where the needling not required, there are the tenosynovitis, either the decurvans, peroneal tenosynovitis, tibialis posterior tenosynovitis. These are all the sometimes MRI findings when you take a MRI ankle. Then we have to give this injection that only in the tendon sheath and never give in the tendons. Now you will find it because there is no way to find out except the feel of giving way while giving the injection, and that you have to develop over a period of time. Then there are different bursitis, right? Retroaceous bursitis, where we have to be very careful because you should remain in the subcutaneous space because tendon chances of the TATR are very high. Then there are certain bursa like trochanteric bursa of the subacromial bursa, which is above the supraspinatus and below the acromion. Then ganglion, it is really very rewarding ganglion. Most of the ganglions are at the wrist. So another indication is local with needling, where needling is done. This is generally at the insertion of the tendon or insertion of fascia like the IT band. Then these are the encisopathies like tennis or the golfer elbow, where there is an insertion of the flexor extensor tendons. Then plantar fasciitis is the commonest. It is one of the most painful injection. Generally, I go from the medial approach and not from the inferior approach, because patient can have a problem with the weight bearing, but one can go from the medial approach, and generally it is one of the most painful injections. So I give the block, ankle block, that also only on the medial side. Not to give, no need to give the sural nerve or the dorsal cutaneous nerve block, only the medial saphenous as well as the medial plantar, the posterior tibial nerve is sufficient. Then for the costochondritis of the second and third ribs, called that Tietz disease. Then other osteochondritis like Osgood-Schlatter's at the knee or the navicular tuberosity. Then local on the painful osteophyte. Sometimes patient doesn't have the much arthritis, and it is there is a classical tenderness at the medial osteophyte. So one can give the injections in the chondral portion of the osteophyte. Then the chronic sprains, when the patient is having ankle sprain like ATFL at the ankle, either it may be at the tibial or at the fibular attachments. Then here also it is very useful. What is sign of the successful injection? Because we put some anesthetic into that, patient have the immediate relief. That is a sign that the injection has reached at the disease part, and patient is having immediate pain relief. Now, as far as back is concerned, cervical spine and the lumbar spine indications, they generally fibromyalgia, there is cervical and lumbar. These are the different points which are given. And second is the chronic radiating pain. About the in upper limb called as the brachial neuralgia, and lower limb called as the sciatica. It's just radiating pain. In the sacroiliitis, in the coccygodynia, and when there is intraspinal pathology like the disc or the canal stenosis, which is without neurodeficit, I regularly give epidural injections for the PID as well as canal stenosis. And even fibromyalgia also, there are many points which are described in the books, but only these 2 points, which is at the posterior superior, rather superior medial angle of the scapula. This is a real point, and this is only very small point of the 1 square centimeter. And similarly, there is a point at the posterior superior iliac spine. These are the 2 real points where we have to give injections to have a very good relief. And foraminal injections, where I don't give the foraminal injections, there is no need for me to give the foraminal injections. What are the contraindications? The absolute contraindication for is the infection anywhere in the body, especially the broken skin near the site of the injection, then uncontrolled diabetes mellitus or any immunocompromised condition, then unstable joints or the fracture, there is one should not give these, and allergy to the constituent of the drug. Then turbid effusion. We have found that especially in the gout, there is turbid effusion in the first TMT joint, and there one should not give. Then unstable coagulopathy. Relative indication of the hysterical patient or the scare patient, especially in the cervical and the plantar, because the plantar fasciitis, because these are the most painful injections. and never given the prosthetic joint. Now, what is the precaution one should take before injection? For any procedure, we have to give the counseling, which is very, very important. Spend more time counseling the patient rather than the injection. Tell him that there are limitations of the injection. In certain conditions, they are gradually, progressively increasing, like the arthritis, osteoarthritis, or the canal stenosis. Just postpone the surgery. It won't. Surgery may be required, but we can postpone the surgery because in all these conditions, revision surgery is generally required. So if we try to have a maximum possible duration of the conservative management and the relief without surgery, it's better. Then one has to explain in certain injections, there is a post-injection exacerbation of the pain. Another complication should be informed to them. From medical legal point of view, there should be a proper consent of all these things. And during injection, when the patient is having fear, we have form one thing from the yoga, that is the Adi Mudra, which I have modified. And I first get it done from the patient. And surprisingly, patient's pain or the fear goes down during this injection. Then check the BSL, as I told you, that will avoid the infection and the strict abscess. But still, I can give the injection up to the 250 milligram% of the blood sugar. Then, especially if the patient is having diabetes or we are giving the bilateral injection, it's better to give 3 days of the preventive antibiotics. Then, while giving injection into the joint, as I told you, we can give right from the temporomandibular to the IP joints. But the injection should go into the cavity. That is very important. It should not go in the capsule or in any other intra-articular structures, not in the synovium, ligaments, or the tendons. Sometimes one has to use the image intensifier, especially for the wrist, ankle, small joints, and even for the hip and the shoulder, where I use the additional arthrography dye. And I ensure that the injection has gone direct into the joint. This is arthrography, which is showing the injection has gone into the joint here. And in the ankle is not required. If you find the needle directly in between these, and when you inject, you are finding suddenly there is a give way and no resistance while giving the injection. Rarely one should go for the ultrasound guided, especially in the shoulder, but because of PC painted regulation in Maharashtra, most of the orthopedic surgeons don't have the ultrasound. What is I have found that methylprednisolone is more effective than the triamcinolone. Generally, I use a 2 cc of the lignocaine or 1 or 2 cc of methylprednisolone with the water for injection where the volume is required. But for the retro HLS, I use hardly 0.2 or 0.4 cc of the methylprednisolone because it should not go seep into the tendo HLS. Now, this is the, as I told you, in the ankle, one can give with the Shyam control. And here, as I shown you, you can find the fluid which is accumulated here in the rather inferior pouch of the shoulder joint. And there you are sure that your needle is into the joint. And sometimes you are find even the whole appearance of the shoulder joint. Then intra-articular injections in the joint. Generally, I use the arthroscopy portal for the knee, shoulder, or wrist, or the ankle. You aspirate the joint whenever possible, because if there is a large effusion, especially in the knee joint, you remove the maximum possible fluid. Here I use the suprapatellar, when the effusion is more, I use suprapatellar approach because it's very easy to remove the effusion. And then you can give the injection to avoid the dilution of the fluid. One has to remember that all these are the blind procedures in the intra-articular. And as I told you, it should not go in the capsule or the ligament. So the feeling of the give way, very important. Especially sometimes you get the feeling of the suction that, and then you can inject there. And after injection, you move the joint in full range of movement to have the better diffusion of the drug into the whole joint. And next injection can be given of the interval of the generally 3 weeks or the 2 weeks. Now, this is one of the video that intraocular injection of the knee joint. Oh, it's not working. Okay, I'll show you video here. Most of the joints are the dry joints. Right. Now the next injection in the wrist joint. This is a rheumatic wrist. When assistant is giving the traction, sometimes I give the traction myself. After injection, you can move in the full range. You can do even the sort of manipulation of the joint in this. And you can the palmar flexion as well as such a complete dorsiflexion. One can go for that. Next is only the ganglion. Here, there is ganglion, which is the commonest site on the volar side as well as the dorsal side. So that it will not enter into the radial artery. So that there the patient shouted because it got broken. Not only injection, it should break. Generally, patient doesn't shout like this. Now we'll go for the local injections of the tennis elbow, where I use the multiple needling technique as well as the injection. Now here we have to find the point of maximum tenderness, and one has to inject there. There also we do get the grating sensations at that site, and you have to just go on injecting at that, around that area. And when you feel the junction between the tendon and the bone, there is always a cartilage metaplasia, and there one can give the injection. So that is the tennis elbow, where you can give massage later on, and you can immediately examine patient for the forced dorsiflexion as well as the passive palmar flexion. The patient gets good pain relief. The next is here is about the local Gerdes tubercle. Now this patient has a typical tendo Whenever there is insertion anywhere, we can go for needling. And then one can have a slight massage. So next is about the fibromyalgia. As I told you, there are specific points of the fibromyalgia, which I call the trigger points. They may not be the site of actual pathology when the patient is having radiculopathy. As I told you, it is in lumbar, it is the PSIS, and it is in cervical, it is the supramodular angle of the scapula. And this particular PSIS nodule, fibrostatic nodule, is a typical one. There are multiple nodules around this, but there is only one nodule, which is the most tender nodule. And sometimes in the fatty patient is very deep. It requires only experience where you can find out that particular nodule. But the injection has to go in that nodule. Sometimes I have to use the epidural needle at that site, in the lumbar area in the fatty patient to reach that particular point. And especially, I have found that in the cervical fibromyalgia, it's a more of a psychosomatic stress rather than the lumbar myalgia. So one has to treat that part also. So as I told you, fibromyalgia injection, these are also, you have to find out the point of maximum tenderness and you have to give it there. It's a really very painful nodule and which slips under the finger. There, as I told you, I require epidural needle, which has to reach up to the bone. And there, just like in a tennis elbow, you have to do the multiple needling, get grating feeling, which is better. You can feel better with the experience. Inject half cc with every needling. Is that most painful at the scapular area and can cause in some of the patients, about 4 or 5% patient, transient intercostal spasm, especially in the very anxious patients. But that reduces within 10 to 15 minutes. I'll show you the scapular injection. How I give this prone position. This is the head end. This is the foot end. Because the patient is already having their anesthetic there, patient doesn't feel pain on that particular grating. Similarly, this is a posterior suprailiac spine injection. It is not much separate. Generally, in the anxious patient, I first give the injection at different places and then I start needling because then the pain goes down. Same as in the scapula. Now, the next injection, in orthopedic surgeons are generally scared of giving the epidural injections, but then it is very easy. Okay, I'll just go for the slide again. That I give in all the PIDs and the spinal canal stenosis only without neurodeficit. I use the lumbar interspinous route. I do in the sitting position because it is very easy to open joint. Patient is also very comfortable, and we have to see that whether patient is on any blood thinners or not. Then just like any epidural injection, any surgical procedure, we wait for 4 to 5 days and stop that blood thinner because at all any epidural vein gets punctured, it's very difficult to control the bleeding. And mind well, this takes maximum 3 to 4 minutes. Sometimes it is in 1 or 2 minutes also. And it's a daycare procedure. We discharge patient immediately after 3 to 4 hours because there is a transient, sometimes the precession in the lower limbs. And very rarely one has to watch for the vasovagal, because that is not directly related to the drug, but it can be related to the vasovagal. That is a psychological, even for initial anesthesia, patient gets that vasovagal shock. One has to be careful about that. And as I told you, that transient hypoxia can be there. And if at all one gets a dural puncture, which is very rare, hardly 1 in 200 or 300 cases, then you abandon the procedure. Now, this is a video of the epidural injection. I have given already local anesthesia. Now, this is a loss of resistance method. You go little bit 2 or 3 millimeters incision, inside, then again use that method. And lately, what I feel, I get the feeling. I go on, I go inside till I get that giveaway sensation. But initial phases, one has to check every time after 2 or 3 millimeter putting inside. So just to avoid the dural puncture. No need to put rapidly, because sometimes that itself can cause a vasovagal. Then it can make the patient sit for is over. Yeah. Generally, I give at least 1 or 2 injections per day. Now, what are the complications is, as I told, there is immediate difficulty in the breathing, and he feels scared, rather he can't breathe, but nothing to worry about that. There was anaphylaxis surprisingly for in 3 patients, but then probably it is because of the, what you say, that not because of the drug directly, but preservative, it can have an anaphylaxis. Where in certain patients, you can have a post-injection exacerbation of the pain due to rebound inflammation. One should be used halocan. In certain cases, I use the BP. We can also see the patient is from the long distance to remain the action for at least 3 to 4 hours till they reach their home. What we do is we start inject oral anesthetics and ask the patient to take cold compress for about 2 days. But in a weight-bearing joints, avoid excessive loading area or for that joint for 2 to 3 days. And we warn the patient that he can have transient mild hyperglycemia for a few days for a diabetic patients. Then there are delayed complications which are mentioned, that the infection, the local immunosuppression, but this is not been observed. And local suppression or sometimes the cartilage suppression, which is told that is a reversible. If you don't repeat within first 15 days, it is a reversible. For subcutaneous area like the retroachealous bursitis or for the decurvans, then patient can have a white spot for some time, but that is a little bit less with the methylprednisolone as compared to the retroachealous. And even for the golfer elbow, which is a little bit more superficial as compared to the tennis elbow. And this white spot can last for 6 months. So use diluted one as far as possible and use very less, 0.2 to 0.4 cc. And of course, you take the consent before that. Tendon attrition, even in the literature, the rate which is given is much less, that less than 1%. That only happens because it's injected into the tendon or around the tendon and excessive exertion, and generally in the tendoachealous. Cartilage suppression is said, but again, literature, it is given only 0.8%. It's a transient, reversible in 3 weeks. So, and second, another reason is the patient start increasing use of the joint because of his pain relief. What are the advantage? These OPD procedures, we can avoid surgery or the postpone surgery in more than 90% patients. And even if we plan the surgery, we can buy the time for the patient surgery, and it can be repeated many times. There is no limit for that. But the interval should be 2 to 3 weeks and is highly cost effective. And here you gain the confidence of the patient. The doctor has tried everything best possible before surgery. And even if he doesn't get the relief because of the patient is ready for the surgery, this can help to improve the image of the doctor also, that he's not a knife crazy. As I told you, there are limitations that accuracy during injection is essential for the doctor. So over a period of time, once you get a practice, it helps a lot into that. And inform that this is a relief for the limited duration. And further, one has to start the multimodal therapy, the positive efforts needed by the patient to prevent the recurrence, that to use a joint judiciously in old patients, and the spine also, they should take proper care of that. Now, in my more than 37 years of the private practice, I use more than injections in more than 3 lakh patients. Out of them, 2 lakhs for the degenerative or the chronic problems. And in 95%, there are more than 80,000 injections. That means I give at least 15 injections, rather I give at least 15 injections per day as far as local injections are concerned. And there are 90% patients satisfied one. Unfortunately, I got now undesired publicity that I'm an injection doctor. So even with the highly advanced arthritis patient, they come to me for the injection. I tell them that you are a now TKR patient, but still I'll give injection as long as you're not mentally ready for getting for any replacement. Because I'm a general surgeon doing everything right from the spine, arthroplasty, arthroscopy, and release around. As I told you, effective counseling required for that. Explain in detail and consequences of degenerative process, that is a gradually progressively increasing condition. What we are doing is just a postponing one. And in the Vat Prakriti patient, the heating 2 days later, for 2 days we the cold compress during the rebound inflammation, but after that heating helps a lot for all the rheumatoid patient as well as the degenerative patient, especially when there is a change in the season like the rainy season or the cold season. And especially for the back as well as for the knees and ankles, the regular and proper relaxing exercises. There are 2 types of basic exercises. One is loading one and the second is relaxing one. There is a relaxing exercise, not a stretching one. The relaxing exercises are important. Then for a psychosomatic component, the meditation does help a lot. I got my own methods of meditation as well as my own exercises are there. And back care, as I told you, stress the importance of back care. You tell them that now your tire and tube is worn out. I have just put the patch on the puncture, but your tube is old one. You have to take proper care of your tire. Use a proper your car properly. Don't go on the bad roads and don't overload also. Then you can have more degeneration. And one can repeat injection if for any recurrence, but not before 3 weeks. Now there is a lot of review of the few papers that intra-articular corticosteroids having large magnitude, and they say that analgesic has to be there combined with intra-articular corticosteroids, because it then acts like just I give the example of the diabetes. Because your blood sugar has gone more than 300 or 400, we are using insulin first, and when the sugar is controlled, then you have to maintain with the medications. Then it definitely has got a superiority over the PRP as well as botulinum toxin. There is a paper, because the evidence is rather inconsistent, and they don't recommend use of PRP or BTA. And for musculoskeletal, they say it is a patient outcome. But this is an adjuvant therapy. That's what I always say. You require further more other therapies, multimodal therapy like the heating, analgesics, back care, and exercise. Or the care of the joint and the exercises. And for rheumatoid also, one has to take proper care during the change of the season. And for psychosomatic patient, the meditation. Then, as they say that this paper tells that this is a new intra-articular treatment option for NEOA, and there is a benefit. There is a far more benefit than the PRP or BMAC or the hyaluronic acid, but it must be carefully weighed against the cost and potential risk. And they new treatment like PRP or BMAC or HA might not be appropriate for every patient. Then this is a position statement of the Arthroscopy Association of Canada that intra-articular injections provide short-term moderate pain relief, and they recommend it as a good A1, while for PRP, they are saying it is a grade C, and for MSC or the BMAC, they say it is insufficient. And epidural injection for lumbar articular, this paper, they say it is a significantly effective result for the patient, and it does have postponed the surgery, especially in spinal canal stenosis patients, for more than 10 to 15 years. So here, another paper which tells do corticosteroids have a place in the treatment of chronic pain? They say it's a part of the multimodal pain management, and the steroids still have a prominent place, but the local steroids, not the general steroids. Now the take-home message is surgery is an option which can be used anytime, but it should be the last option. Patient should buy surgery, and we should not sell it. Patient should say now all the conservative management has been given, and now kindly I am ready for rather surgery. Intra-articular or the local injections help a lot to avoid in many patients and to postpone the surgery. But there has to be adjuvant multimodal therapy which has to follow over that. So in this multimodal therapy, we go for the nature. So don't try to go above or win over the nature, and be with the nature and help the natural processes. Thank you very much. So this is the one advice which is given by Dr. Lord is be godly, but don't try to be God. Be with the nature. Thank you.
Thank you, Karne sir. So, do you ever get any anaphylactic reaction when you use this local anesthetics along with the steroids?
As I told you, in 3 of the patients, we have got anaphylaxis, but see, the treatment of the anaphylaxis is the steroid. So steroid cannot give the anaphylaxis. So it is the preservative which is used for the steroids. Steroids, or even maybe for the lignocaine or sensorcaine that might have given him. Rather, in one of the patients, I have to put the tube. The patient has got such anaphylaxis, but it is very rare. As I told you, out of rather more than 2 lakh patients, hardly 3 patients have got it. But you should be mentally prepared for everything. I think one of these, after epidural injection, of course, the patient was already operated elsewhere and he has got severe adhesions everywhere. And he was HIV also. But in him, we got a severe reaction that we have to put him a tube for epidural injection. But that is for like any other anesthesia.
So you recommend it to be done in a setup where we have all the backup facilities, not only in like. Do you recommend to do this in clinics where we don't have all this?
See, these days, even the CPA or all these things, they are saying that all the clinics should be occupied, or rather should be, there has to be a provision of the treating anaphylaxis. But even if you give the simple analgesic injection, I have seen the anaphylaxis for the, even for the diclofenac, we have seen the death as well as we have to put a tube for the diclofenac injection. So if you are giving any kind of injection in the OPD, rather it will come in future, whatever coming in that law, I forgot the name of that law, but it's coming here in Maharashtra, then because if they're in Delhi, every clinic has to be occupied with all this such management very easy. And that doesn't require much. In the OPD setup also, you can have a tube. What is required? A simple ambus bag and the tube. Nothing else is required, and the laryngoscope and all the emergency injections.
Yes, Prakash.
Number 1, there is no anaphylaxis in either steroid or xylocaine. We have to write it on a stone. It is a preservative of xylocaine that causes anaphylactic shock in less than 1% of the patients. If you use cardiac xylocaine or xylocard, you will never get anaphylaxis because that is preservative free. Only problem with xylocard is it's a 20 ml vial and you cannot use it for more than 1 day because even if you keep it in the fridge, after 1 injection, you will start getting fungus.
My connection is unstable, or I can't hear sir's voice.
My voice is not clear?
Sir, L Prakash, your voice is clear. Karne sir, तुमचं थोडंसं हे आहे.
Karne sir का गया, हाँ. So the basic idea is if you do not discard the xylocard, next day it will get fungus. So xylocard has to be used and thrown away. People are using xylocaine only because they want to use it for more than 1 day. With xylocaine and steroid, patients get a syncopal attack, which is not anaphylaxis. A syncopal attack is sudden disappearance of pain. Give them a syncope, a head raise, and give a little adrenaline, and the patient will become all right.
That is vasovagal. That is vasovagal.
That's a vasovagal attack.
Yeah.
So I do not use conventional xylocaine with preservative for any of the blocks which we do, portal blocks which we do. I charge properly and I use xylocard, which is preservative-free xylocaine and steroid. And in a combination of preservative-free xylocaine and steroid, you cannot get anaphylaxis.
That is a good suggestion. Rather, we have started doing xylocard for the epidurals now.
Yes.
Because we may puncture the epidural vein. So after that particular test,
our conjuicy that after using 2 ml, we have discarded 18 ml. And we can't use big ampoules the next day. We are doing the conjuicy. That's just and once in 10 cases or 1 in 100 cases, we are facing the trouble.
But within 24 hours, it gets fungus.
Within 24 hours, it will get fungus because it doesn't have preservative. Xylocard, if you don't finish in 24 hours, it will get fungus. You will get fungus layer on the top, even if you keep it in the fridge.
Okay.
So
that is a good suggestion.
Has got that parabiran something, which is the preservative.
You have given to me. That is a good suggestion. You have given to me.
So that is the reason why we get the anaphylaxis. Again, if you dilute xylocaine to 0.5%, effect is the same, but chances of even vasovagal and syncopal attacks are very, very low. Because in our portal blocks, we give some, in a particular patient, 10 spots, 12 spots, and if 10 ml, 12 ml, we are giving different spots. And then there are clinicians who are giving 100 patients in a day, 50 patients in a day, and they are now giving for the last 1, 2, 3 years, and they have not had a single problem. So anesthetists have learned from us how to avoid anaphylactic shocks. So I always say
that training is required for every general practitioner now. General practitioner also should understand how
using for local anesthesia.
everybody should know it. Even dental surgeons now are learning how to treat
Don't
anaphylaxis.
use xylocaine, use xylocard. It is little, it's only 10% more expensive per vial to vial. But because you cannot, unless you have a roaring practice where you're using the same vial on 10 patients in a single day, you have to throw it away. Same with clonidine. 1 2 ml vial has got 200 micrograms. You're only using 20 to 30 micrograms per patient. So if you're getting 2 patients, balance you have to throw away. You can't store or save. These are only small tricks.
Right.
Karne's talk was very, very good, and I think you have went in very detail. And I should thank you that you've done a very good job. And together we'll do a very good work on office orthopedics. So Ashok's question basically, actually what Dr. Karne sir has taught is an office orthopedic procedure. You do not need a theater, you don't need an endoscope, you don't need to intubate the patient, you don't need laryngeal mask, you don't need oxygen cylinders. But once in a while, if something happens, you must have the IQ to head raise, give adrenaline, and have an anesthetist on call who will come within a few minutes to intubate a patient should it be needed. So we should always have somebody on call to help us, but doesn't mean that I have to make him sit in our OP for the whole evening waiting for something to happen, because it's not going to happen. So
we ask the patient to wait for 10 minutes.
After all those procedures, you ask the patient to wait 15 minutes.
Within 10 minutes, if nothing happens, then nothing happens afterwards.
15 minutes. All my patients wait 15 minutes in the post-op room, and they come back and I take a video of their movements or whatever and record their statement saying that yes, before the injection I was like this, after injection I'm like this, then only I send them.
Right. Thank you, sir. Thank you, Dr. Karne. Thank you, Dr. L Prakash, for a nice discussion also. So for this month, for last 4 weeks, we are having this seminar on office orthopedics. Thank you, West Zone Indian Orthopedic Association, for supporting us in this venture. I also like to thank OrthoTV, Neeraj and Poonam, who are there to help us. And I declare this session to be closed. Anything else, Dr. Karne?
No, any questions on this?
Sir, yeah, online.
Facebook
I have not,
this YouTube.
No. Yeah, Poonam, Ms. Poonam, do we have any questions on YouTube or Facebook? I think they are not online. So
No, they are not online. Yeah. No problem.
Okay.
Because
Thank
we have
you
got
so much,
171 views. Good. Yeah.
Thank you so much, sir. Thank you. Thank you all of you.
Yep.
Thank you.
Thank you.
Thank you, sir.
Everybody.
Thank you, Karne.
Thank you. Yeah, thank you.